Today we have talked about four main things. First of all, we have talked about thrombosis. Then we have discussed about embolism. Then we have talked about edema, and then at the end we have talked about shock. So now I'll give you a quick review about these four terminologies. Maybe you can come here. Starting from the very beginning, thrombosis. We have talked about thrombosis as it is a pathological process of formation of intravascular blood clot. And then we have talked about its location. Localization of the thrombus is maybe artery or maybe vein, but most common location is deep vein thrombosis, which are present in the leg below the knee level. Then we have talked about some differential diagnosis between thrombosis in a living being and thrombosis in a post-mortem, like after death. If we talk about some its characteristic features, the thrombosis in a living person usually attaches with the blood vessel wall, and it has characteristics of line of Zahn. It's the lining of the fibers and platelets, fiber and platelets separated by the red blood cells. But post-mortem, thrombosis has four main characteristics. Number one is attachment. They do not attach with the blood vessel wall, the person who's died, and they don't have line of zones. Like these are the lines made by the fibrins and platelets separated by the red blood cells. And number three, most important, that a post-mortem blood clot, it resembles the shape of the blood vessel. If the blood vessel is small or bifurcated, the blood clot will be like that. And lastly, we have discussed that the post-mortem thrombosis have a characteristics of it being soft and rubbery. And if we talk about, on the contrary, thrombosis in the living being, it must be hard. So then we have talked about biopsy and autopsy. There is no fun in telling that bio means lives. If we take a sample of a living cell, it is called biopsy. And if we take sample in post-mortem or in forensic medicine, it is very useful, autopsy. Then we have talked about Virchow's triad. It's a German scientist who told us that three features which are very important if we talk about thrombosis, for the formation of thrombosis. First of all, we will talk about blood flow disruption, then we will talk about subendothelial damage, then last we will talk about hypercoagulability. For blood flow disruption, we have talked that normal, the blood flow is streamlined or laminar blood flow. Like RBCs are moving in the blood vessel in a straight line, and then we have line for the platelets, line for the coagulator factors. All the material within the blood vessel are going in a very sequence and in a very organized manner. It is called laminar blood flow or streamlined blood flow. But if there is any disturbance in this blood flow called turbulence blood flow, that are a risky statement for the blood flow disruption. There are three causes for the disruption of the blood flow. Number one, we talk about myocardial infarction or arrhythmias. These are the features that can disturb the normal streamline or laminar blood flow. Then we have talked about aneurysm. What is aneurysm? It is called abnormal dilatation of the blood vessel wall. You can see, if you can zoom in, due to the abnormal dilatation of the arterial wall, the streamline or laminar line flow of blood becomes turbulent. You can see like this. Due to this turbulence, there is increased risk of thrombus formation. Then lastly, we have talked about immobilization, or immobilized person is immobile. Then stasis of the blood increases the risk of thrombus formation. Then we have talked about the subendothelial damage. Normally, we have talked about what are the features of endothelial cells. First of all, they protect the subendothelial tissue or collagen. They secrete the nitric oxide and prostaglandin I2. Their functions are vasodilation and inhibition of the platelet aggregation. And then they also release heparin-like molecules, which will increase the endothrombin 3 level, which will inhibit the thrombin and coagulator factors. Then, yes, you can see over here. Number one is protection. Number two, prostaglandin I2 and nitric oxide for vasodilation and platelet aggregation inhibitors. Then heparin-like molecules like antithrombin 3 increases, it will inhibit the thrombus and coagulation factors. Then tissue plasminogen activator, it will convert the plasminogen into plasmin. What are the functions of the plasmins? Inhibit the aggregation of the platelets and coagulator factors and inhibition of the thrombus. So that's the normal function. So what are the features which causes the subendothelial damage? First of all is atherosclerosis. We have talked about that increased level of cholesterol. We start building up with the vessel wall. And then we have to assess vasculitis, inflammation of the vessel wall. Then homocysteine. For homocysteine, increased level of homocysteine can damage the subendothelial tissues. There are few features like if there is a deficiency of vitamin B12 or folic acid. Normally, vitamin B12 and folic acid converts homocysteine to the methionine. But if there is a deficiency of vitamin B12 or folic acid, then it means there is no conversion of homocysteine to methionine, and increased level of homocysteine will end up with the subendothelial damage. Then we have talked about the cystathionase beta synthase enzyme, which converts homocysteine to cystathione. But due to deficiency of this enzyme, there will be increased level of homocysteine, and that will damage the subendothelial tissues. Then lastly, we have talked about hypercoagulability. If there is increased level of coagulator factors or decreased level of anticoagulants or defective anticoagulants, that will end up with a feature called hypercoagulability. First of all, we have talked about protein C and protein S deficiency. These are the proteins which gives a negative feedback to the coagulation pathway or complement system, which you can say it inhibits the factor 5 and factor 8. But if there is a deficiency of protein C and protein S, there is no inhibition of factor 5 or factor 8, which means factor 8 and factor 5 will be more stimulated, and there will be more formation of the clot. Then we talk about warfarin, a drug that also causes the decrease in the number of protein C and protein S. So beware if the person is having protein C or protein S deficiency already, better not to use warfarin at that moment. Then factor V laden, it is a mutation in the factor 5. Due to this mutation in the factor 5, there is no negative feedback by the protein C and protein S on the factor 5. And this is the most common inherited hypercoagulable condition. Then we have talked about oral contraceptives, estrogen, which increases the production of coagulants. So due to this, coagulability state will be higher. Then prothrombin 20 or prothrombin 20210, it is a mutation called point mutation in the prothrombin, and which will end up with the prothrombin or thrombin formation. Then we have talked about this extrinsic pathway, intrinsic pathway of coagulation. You can see over here, tissue thromboplastin will activate the factor 7, factor 7 will activate the factor 10. This is extrinsic pathway. Our PT, prothrombin type, depends on this pathway. Then we have subendothelial collagen damage, which will stimulate that factor 12, factor 12 will stimulate the factor 11, factor 11 will stimulate the factor 9, it will stimulate the factor 8, and it will stimulate the factor 10 again. This is intrinsic pathway. Our APTT level depends on this pathway. And from the factor 10, there is a common pathway. Factor 10 will stimulate the factor 5, it will stimulate factor 3, and at the end, stimulation of the factor 1 will stimulate the fibrin formation. So that was about thrombosis. Then we have talked about embolism. It is the intravascular mass which occludes the blood vessel. And there are two types of embolism, thromboembolism and atherosclerotic embolism. Thromboembolism is 95% of the cases, and atherosclerotic embolism only 5%. And there are three types of embolism. We have talked about fat embolism, gas embolism, and amniotic fluid embolism. Fat embolism, there are two main reasons. Number one is fracture of bones, especially the fracture of long bones. Due to the fracture of long bones, there is the bone marrow and the fat enters into the blood vessel. So then second one is soft tissue trauma. Another is cause or etiology of fat embolism, and this fat embolism, when it enters into pulmonary vessels, it will cause dyspnea, difficulty in breathing, and it will cause small tiny bleeding spot over the skin called petechia over the chest. So these are the features of fat embolism. Then if we talk about gas embolism, it happens mostly in decompression sickness. What is decompression sickness? Rapid decrease in pressure of water and air in our surroundings. It mostly happens scuba divers or deep sea divers. We have talked about the person who is diving till the 40 meter. It is called scuba diver, you can say. And if they go beyond the 40 meters, they are the deep sea divers. When they came up from their journey under the water, there is a rapid decrease in the pressure that will cause a decompression sickness. There are two pathologies. First of all, we have talked about laparoscopic surgery, in which there is a chances of entrance of gas into the abdomen. And second one, Caisson disease, in which there is a multifocal necrotic tissue over the bone, and due to the nitrogen bubbles impinge or struck with the blood vessel wall of spinal cord and brain. Yes, so it will cause the neurological features also. And there are two main things I forgot in 30 minutes before. That is bends and chokes. There is a pain in the joints and muscles, that is called bends. And due to the respiratory disturbance, the respiratory illness, dyspnea, and all the features related to the respiration is called chokes. Bends or chokes are the features of gas embolism. Don't forget this thing. Then, lastly, we have amniotic fluid embolism, because amniotic fluid is very, coagulable. Coagulability is higher in this amniotic fluid embolism. Amniotic fluid during delivery or during labor, it enters into the bloodstream and cause the neurological symptoms, and most importantly DAC, disseminated intravascular coagulation. Then yes, if we talk about embolism, there are two types: systemic embolism and pulmonary embolism. Systemic embolism mostly due to left ventricular heart failure, and most common arises from the left ventricle, and most common location is lower limb. If we talk about pulmonary embolism, most common cause is deep vein thrombosis, thrombosis of the popliteal vein, thrombosis in the femoral vein or iliac vein, and it remains mostly silent. Why silent? Because of one first property is due to having dual blood supply, and second one is because it is self-resolving capability. But in spite of these two features, if the size of the thrombus or embolus is high, then it will show some features like shortness of breath, dyspnea, hemoptysis. What is hemoptysis? There is a blood on cuffing with cough. So pleuritic chest pain, pleural effusion, or water in the pleural cavity, or ventilation perfusion mismatch. Mostly the perfusion problem is there, because ventilation is normal, but due to embolism, perfusion is disturbed. And then we talk about saddle embolism. If there is that embolism present at the main trunk of pulmonary artery, it will obstruct the major part of the lungs. So saddle embolism will lead to this sudden death due to electromechanical failure, because heart as a pump had to force that mechanical obstruction called embolism. So that will ends up with a sudden death. And talk about diagnosis. Diagnosis of choice is Doppler ultrasound that will detect the DVT. And D-dimers are very helpful because they will indicate the breakdown of fibrin. Then spiral CT will show us the filling defect. Then if we see there, we will see hemorrhagic wedge-shaped infarction will be seen in pulmonary embolism. Then we have talked about edema. What is edema? Increased fluid in the interstitial space. Fahad, can you hear me? Yes or no? Yes. So please focus over here. Increased fluid in the interstitial space. There are few types of edematous fluid. Number one is transudate fluid, or transudate or exudate, or lymphedema or mixed edema. Transudate edema or transudate fluid having proteins less than 3 mg per deciliter, having specific gravity less than 1.012, and these are the cell poor fluid, and there is increased hydrostatic pressure and decreased oncotic pressure. And these features of transudate fluid will gives us a more specific feature, that is pitting edema. If you pressurize somewhere, someone having edema over the leg, if you give some pressure, it will, and after removing that pressure, there will be pit formation. That is characteristics for transudate edematous fluid. Then transudate fluid, it happens in organ damage, but exudate fluid or exudate edema happens in local infection or damage. But the most importantly, two main features that will ends up with the transudate fluid are liver cirrhosis and left ventricular heart failure. Then we talked about exudate fluid due to local infection or inflammation or damage. Proteins are more than 3 gram per deciliter. Specific gravity is more than 1.021. Cells are rich in fluid, and so that was the feature. And non-pitting edema is the feature of exudate fluid. Then we have lymphedema. We have talked about breast lymphedema, that is inflammatory carcinoma. The malignant cell will will block the subcutaneous lymph vessels. Then we talked about After lymphedema, mixed edema, feature of hypothyroidism, in which there is increased level of hyaluronic acid and chondroitin sulfate. Hyaluronic acid is the having property of hydrophilic, water loving. Then acrophobia, if we talk about hydrophilic, we must talk about hydrophobia, which is a feature of some disease called migraine or photophobia. Then acrophobia is the fear of height, and claustrophobia is fear of crowded places. Then there are types of edema: localized edema, local edema, and generalized edema. Localized edema, most common cause of localized edema is inflammation. Like in thrombophlebitis, there will be edema of the respective or specific limbs or organs or trachea or larynx. And immune reaction, urticaria or hives, and then angioneurotic edema in larynx. Then if we talk about generalized edema, due to the heart failure, liver cirrhosis or nephrotic syndrome, and severe form of generalized edema is called anasarca. And there are lymphedema will be there. If there is MRM, modified radical mastectomy, radiations or filariasis, it will end up with the lymphedema. And then there are few things in generalized edema: periorbital edema, or you can say puffy eyes. It happens in renal failure. And then we have talked about dependent edema, or it is called gravity-induced edema. It happens with congestive heart failure. Then there are edema can also present in pregnancy due to uterus puts a pressure. Heavy uterus puts a pressure over the blood vessels of pelvis, especially the veins and vena cava also. And prolonged sitting or standing will also lead to edema. Suppose a person is sitting for a long time or standing for a long time, so there is inactivation of the muscles of the periphery, and due to inactivation of the muscles in the periphery, there is no flow of fluid or blood from periphery to the heart, because as we know, when we walk or when we do some activity, due to the contraction of the muscle, the fluid from the periphery will go to the heart by a negative feedback mechanism, which we have talked about soleus muscle, that is called second heart of the body. Why? Because when we walk, then soleus muscle present over the calf, it will contract and it will gives blood supply and all the fluid present in the periphery, especially the lower limb towards the heart. So that was about edema. Then we will talk about shock, and there is a differential shock or the stroke. What is stroke? This is the death of brain cells due to the any clot in the cerebral vessels. And what is shock? It is a generalized hypotension. Hypotension, hypoperfusion. Hypoperfusion. So it is a generalized hypoperfusion due to decreased cardiac output or ineffective blood circulation. Then there are few types of shock. First of all is cardiogenic shock. In cardiogenic shock, we have decreased cardiac output due to two reasons. There is a damage of intrinsic myocardium or extrinsic myocardial damage. If we talk about intrinsic myocardial damage, the examples are myocardial infarctions or ventricular arrhythmias. Then if we talk about extrinsic myocardial damage, the specific or most important example is cardiac tamponade, in which we have fluid in the pericardial sac. We have talked about that pericardium has two layers: visceral pericardium and parietal pericardium. In between these two layers, we have a fluid accumulation that will put a pressure from outside towards the heart. It is comes in extrinsic myocardial damage, and it will force the heart not to work well, not work properly. And for cardiac tamponade diagnosis, we have triad called Beck's triad, in which there is a decreased blood pressure, there is a muffled heart sound, or decreased intensity of the heart sound, obviously due to the presence of fluid. Suppose if you can listen, auscultate a patient normally without any fluid barrier, you can hear well. But if the other person with cardiac tamponade, it is having a double layer or even extra layer of fluid, then it is very difficult to listen that heart sound properly. So muffled heart sound or decreased intensity of the heart sound. And distended neck means, obviously if the heart is under pressure already, it is not possible for all the veins to go to pour its blood to the heart. So due to that pressure, the neck veins will be distended. These three features are called Beck's triad, important for tamponade diagnosis. Then We have talked about septic shock. Any microbe in the blood is called septicemia. If we talk about pathology, gram-positive bacteria like Staphylococcus aureus, they have a structure called lipoticoic acid that will secrete tumor necrosis factor. For septic shock, tumor necrosis factor alpha is very important. And tumor necrosis factor alpha will stimulate the interleukin 1, it will stimulate the interleukin 6, and all the pathogenesis happens. Then gram-negative bacteria, example is the E. coli, having structure called lipopolysaccharides or endotoxin, that will stimulate the complement system coagulation pathway, that at the end will stimulate the complement system, and there are risks for disseminated intravascular coagulation or multiple organ disorder syndrome, and this is the most common cause of death in septic shock. And septic shock, this is most common cause of death in ICU is also due to septic shock. Mortality rate is almost 30 to 40% is mortality rate. And there are few features in septic shock. First of all, decrease jugular venous pressure. The normal jugular venous pressure is 6 to 8 centimeter of water. But in septic shock, there is decreased jugular venous pressure, warm body due to the vasodilation, tachycardia, and strong or increased peripheral pulses as the heart is on the compensatory mechanism. Due to compensation, the heart is pumping more than usual. Due to that, the peripheral pulses are strong. And if you talk about most common cause of septic shock, infection of the lung. Lung infection mostly causes septic shock. Then number 2, blood. Number 3, abdomen. Number 4, urinary tract, and number 5 is skin infections. So this sequence you must not forget. Then we have talked about anaphylactic shock, generalized hypotension. It is an example of hypersensitivity type 1. Because there is a pooling of blood in the periphery. Then hypovolemic shock, decreased cardiac output due to loss of blood, loss of plasma, loss of fluid. In which condition there is a loss of blood, any fracture, most importantly pelvic fracture or femur fracture. Loss of plasma in burns, first degree, second degree, third degree burn we have talked about. The loss of fluid, most importantly vomiting and diarrhea. Vomiting and diarrhea, loss of fluid is the most common cause of shock nowadays. Then we have talked about neurogenic shock. In neurogenic shock, vasodilation due to the anesthesia or injury to the spinal cord. And there is a triad you should not forget in the neurogenic shock called Cushing triad. What happens in Cushing triad? There is increased intracranial pressure, increased blood pressure or hypertension. What is blood pressure? It is the pressure of the blood over the walls of the blood vessel wall. So in Cushing triad and neurogenic shock, there should be increased intracranial pressure, increased blood pressure, hypertension, and bradycardia. Then at the end we have talked about 3 stages of the shock: compensatory stage, then or progressive stage, or reversible stage. Then we have talked about second and third. First of all, compensatory stage is also called reversible or non-progressive stage. What happens? In first stage, there is generalized vasoconstriction except the vital organs. Like vital organs are getting normal blood supply, but the other organs, other than vital organs, they will have a vasoconstriction in the blood vessels. So due to this vasoconstriction, the skin should be calm, or you can cool, not calm, coolness of the periphery, and tachycardia as a compensation. Then skin will be paler. Then dizziness, neurogenic shock, and kidneys will try to hold the fluid as much as they can, so there will be decreased urine output. Then secondly, the second stage is progressive stage or decompensatory stage, in which there is a metabolic or circulatory disturbances there, and lactic acidosis phenomena in the second stage of the shock. Due to lactic acidosis, there is a vasodilation and decreased cardiac output that will cause the anoxic injury to the endothelium that will leads up or ends up with the disseminated intravascular coagulation. Then at the end, third stage or refractory stage or irreversible stage, in which there is a survival is impossible because the cell or tissue damage are so severe. And what are the features in refractory or irreversible stage of shock? What happens to the brain? There is encephalopathy and necrosis will be there, cortical necrosis. In heart, there is coagulative necrosis and contraction band necrosis will be there. And in lungs, acute respiratory distress syndrome are mostly alveolar damage. Most important shock is septic shock, because rest of the shocks mostly lungs are resistant, but in septic shock they are also sensitive to septic shock. In GAT there is hemorrhage and necrosis, kidney acute tubular necrosis, and in liver congestion and necrosis, and adrenals leading to lipid depletion. So that was about today's class. If I left something, please let me know.
So dependent edema, please revise.
Dependent edema, it is a feature of generalized edema. Happens in congestive heart failure. Gravity induced edema. If there is edema, it differs with the gravity. If you are walking or you are stand up, edema will be at the lower legs or lower knee, you can see. If you are lying down, edema will be that side that is attached to the bed. So it depends on gravity. Gravity induced edema or dependent edema due to congestive heart failure. Thank you so much.